welcome to Basic Black. Some of you are joining us on our broadcast and others of you are joining us on Facebook and Twitter. I'm Callie Crossley, host of Under the Radar 89.7. Tonight, racism, the real public health crisis. We, like you, are dealing with the effects of the coronavirus pandemic and are taking precautions. We are working with limited staff and our guests are joining us remotely. No longer up for debate, communities of color have suffered the worst health and economic losses because of the coronavirus. Less understood how that vulnerability is linked to a history of segregated policies. Cities like Pittsburgh and Milwaukee have offices that regularly evaluate racial inequities, a model Boston is discussing. Could that ensure more equity in assessing aid and resources? And what does that have to do with the crisis happening at this moment? Joining us, Boston City Councilor Ricardo Arroyo, who represents District 5, which includes Hyde Park, Mattapan, and Roslindale. Jean-Luc Pirit, President of the Board of Directors of the North American Indian Center of Boston. Dr. Vanessa Northington Gamble, University Professor of Medical Humanities at George Washington University, who is internationally recognized for her expertise in the history of American medicine and racial and ethnic disparities in healthcare. And Dr. Thea L. James, Associate Professor of Emergency Medicine at Boston Medical Center, Boston University School of Medicine, who also serves as the Associate Chief Medical Officer, Vice President of Mission at Boston Medical Center. Welcome to all of you.
Thank you.
Councilor Arroyo, I'm going to start with you because you recently introduced a proposal to the Boston City Council that there be a naming of racism as a public health crisis. Now, as we've said, this follows on the heels of other cities that have gone this direction. I'm thinking of Milwaukee specifically. Last year, that means pre-COVID-19, they put in place a directive and acknowledged that racism was a public health crisis. And that's something you would like to see happen here. Why is it important to, as you say, name it, shame it, so that we can change it?
I don't think we address problems that we don't discuss and that we don't put in public light. And the reality is that racism as a public health crisis is not new. All the data backs that up. All the evidence that we have when it comes to health equity and health outcomes proves that racism plays a very determining role in inequity and in furthering those gaps. Prior to COVID-19, this was filed, and I think COVID-19 has really done a number on our communities, has really shown the size and the enormity of those disparities that have been with us for generations. And the goal with this ordinance was to name it, to make it a very public thing, that racism is playing a role in people's health, that racism plays a determining role in some cases in people's health, and that we should be trying to address that in all the different ways that are available to us. And I think one of the small things that I would say about this was it also came with a solution. And the solution was to create a social equity office that takes a look at everything that the municipal government does from a policy or legislative standpoint and says, does this raise social inequity? Does this lower social inequity? Does this have no impact on social inequity? Because it's really important to understand that when we talk about health determinants, we're talking about things like asthma that are caused by environmental policy, that are caused by the way that we treat our neighborhood. When we talk about diabetes and things of that nature, we're talking about diets and food and what we make, what our policies are around these things. And so there's a number of different outliers from public policy that create these effects. And so this legislation was to do that, to address this head on.
So, Dr. Gamble, there is a connection between what has gone before and now. And the reason that underpins why Councilor Arroyo is interested in getting this exactly named, because I'm sure people are listening saying, so what, you name it. I want to read you the beginning of an article from The Undefeated, which says, in American epidemics, race is a pre-existing condition. And you have shown that the flu epidemic of 1918 is directly connected in many ways to what's happening to folks of color right now. Can you put that together for us about why it's important that we understand this connection?
Yes, first of all, it's race and racism that determines what happens in epidemics. And the reason I make the distinction is that one, as the councilman talked about, is that racism is a public health issue in that where one works, where one lives, what kind of health care one gets determines health. And if you look at this historically, in the 1918 influenza epidemic, this was a time, and it still is, I think, very current, where there's this belief that Black bodies are different, that there's something about Black bodies that makes African Americans vulnerable to diseases. You saw that in 1918. But in 1918, it also was a time where this was not just the time of the influenza epidemic, it was the time of World War I, but it was also at the time of very rigorous and strenuous xenophobia and also racism. This was where during the time of Jim Crow. So you found that African Americans had to take care of themselves, that because they could not go into white hospitals, that it was the Black community that took care of itself. And I think we're seeing that now, that the Black community and other communities of color are bearing the burden of trying to take care of themselves.
So, Sean Parikh, that's right where you live, because as someone who is a part of the Native American community, you have seen your community really be ignored. I think a fact that many people don't understand is that 78% of indigenous peoples live in urban areas. And yet, as we've heard the impact of COVID-19, it's really mostly been focused on reservations and Native Americans. Talk to me about why it's important to have those numbers.
Yes, and where I live, it's traditional indigenous Massachusetts Nation territory. I myself am a member of the Tunica Biloxi tribe of Louisiana. And, when we were going into this year, 2020, we were called to reflect on the 400th anniversary of the landing of the Mayflower. And yet, what we're seeing right now is more of a mirroring than an actual reflection of history. So our community is going through this pandemic. Back then, there were epidemics of smallpox, and it's coupled with this sort of like land grab effort. So we saw earlier this year that the Trump administration moved to disestablish the Mashpee Wampanoag tribe reservation. And thankfully, with political support, especially from Councilor Arroyo's colleagues at the Boston City Council, we're able to get resolutions, we're able to garner political support towards the effort of protecting that land. But again, from the state level on down, we're not being reflected. Our communities is not being distinguished in the reporting from the private labs, healthcare providers, and other partners of Department of Public Health. And so our numbers are not showing up in these reports. And it makes it very hard for an organization like North American Indian Center of Boston to talk about the actual impacts. Yes, we see day to day. We actually have a PPE making campaign. We're joining with South End Technology Center and the Party for Socialism and Liberation towards making PPE. I'm actually speaking from Boston to rent space from us at NACOB, and they have their own PPE making initiative. But getting out into the community, collecting these stories, this is the sort of grassroots efforts that we are doing in order to get data for our community.
So there's no question in your mind that racism is a public health crisis when it comes to indigenous people.
Yes, racism, and of course, we go back to colonialism as well. So
okay.
It's part and parcel of the agenda.
Got you. Dr. James, you're on the front lines. You are seeing those cases come in. You said you've seen the numbers, so you know what's the impact is in communities of color, and yet you understand, based on some work that actually the Boston Medical Center is doing outside of the emergency room, that this is really connected to structural barriers. Please talk about that.
Exactly. Well, this is obviously the data, the way the data has played out, even in our own hospital, is no surprise to any of us. The majority of our patients are patients who come from disinvested communities. And having come from those communities, they have not had the opportunities to, I would say, fully participate in the economy, because those communities are undersourced, and they impact things like education attainment, housing, economic mobility, all of those things that are directly connected to health status. For example, people with lower incomes have worse health status, and so do their children as beneficiaries of their parents' resources. The same for people with lower education attainment. And so, what we see every single day, we understand that we are essentially, and pre-COVID, we understand every day that we are merely resetting people back to where they were and then discharging them back to what's driving their chronic states of and perpetual states of instability. So we are always focusing on, especially in these days, focusing on root cause and attempting to disrupt the structural barriers and not to focus on just filling gaps for people, but eliminating gaps using an equity approach so that people can achieve at their highest levels and greatest desires. And so, we have been focusing on things like employment and housing and using various different innovations and different ways of approaching these things so that we can eliminate the root causes of what drives what we're seeing. And in our hospital, we essentially became a COVID hospital. I mean, we had a really early surge in late March. And what I just stated was in the data, like 65% of our patients who were in here during that time were people who had high school degrees or lower, and people who lived in multi-generational housing. And it just, it doubled their presence here between this year and last year. For example, 80% of the people who came in here for COVID were people who were Black, African American, and Latinx people, for example, whereas last year it was around 59% this time. So it didn't surprise us. We did what we had to do, to manage it, and it was an interesting, phase to go through. We're still going through it, but
Yes.
the numbers are decreasing for sure right now. But we're focusing on, where we want to be.
Right.
Where should we be? Not getting back to where we were, because that wasn't an ideal space.
So, Dr. Gamble, were there any lessons learned from that history, that terrible history of the 1918 flu pandemic, which seems to be mirroring exactly what's happening now? And why are we here? We understood what happened then, or did we? Maybe that's the question. Yeah.
Yeah, I mean, I think that is a question.
Yeah.
What did we learn? I mean, because the other thing too about the 1918 influenza epidemic, it was a time where there was these beliefs that Black people were going to be extinct because their bodies were so inferior. This is also a time where Black people and also Asian people were seen as, and also Mexicans were seen as the germs. That instead of thinking about bacteria, it was the people. We're seeing that now with the xenophobia towards the Asian community. That also was happening in the early 20th century. So we have that. The other thing, so we see the impact of racism on how we deal with epidemics, how we look at the people who are suffering from disease. The other thing that came up in 1918 was this belief that African Americans, did not deserve health care. That people were dying from the flu, but were not allowed into white hospitals. The other thing that came out of this and about reporting, there was a belief that African Americans did not suffer the flu the same way in 1918 as other groups of people. That might have been because of underreporting. I've also seen African Americans saying that's because of segregation. Segregation was a form of quarantine.
So, Dr. Gamble, we're seeing right now folks turned away from the emergency room saying, no, you don't need treatment. So That seems to me an echo of what you're saying.
That is definitely an echo. Another echo that in my research, I was doing some work looking at the influenza epidemic in Chicago, and reading from the Chicago Defender, where the African Americans in Chicago were saying that they had to close down the jail because the jail in Chicago was the highest breeding ground for influenza. Echoes of today in terms of the incarcerated. I mean, one of the things, the lessons, I think one of the major lessons from the 1918 influenza epidemic was that when it left, the concerns about people of color and disease left with it.
Got it.
And so that I think that this is a time, that we really need to think about racism as a historic public health issue. And so not just to stop when the epidemic goes away.
So, Councilman Arroyo, that brings me back to you, because I can't tell you how much stuff I've heard and read during this, particularly when that first racial data came out that, by the way, our Congresswoman, Ayanna Pressley, has called for more of, that people said, this is not a race thing. The virus impacts everybody. So when you mention race and racism as a driver of this, you get pushback. How do you get first the council and then the city to sign on to what Milwaukee, Pittsburgh, and other cities have done? And what difference will that make if they do, if it does?
So I would start by saying that I think the council would sign on to the racism as a public health crisis. I think what's equally important to have everybody sign on to is solutions for that, right? I don't think anybody's interested in restating the problem. And when we have pushback on this, because you're right, we get it, it's a misunderstanding of generations and generations of systemic ill here. The reality is, when you talk about African American and Latino communities, they've been let out of so many of the different ways in which this country has let in raise people up, whether it's the GI Bill, whether it's being the direct on the negative end recipient of redlining and making sure that they're blockbusting and doing all of these things to create neighborhoods and create poverty concentrated in ways where that opportunity to move forward in America has existed. That just by that happening has created all these different health disparities over generations of time. And so, when you look at public health crises in America, there isn't one in which people of color don't suffer the brunt. It just doesn't exist, whether it's a health disaster, whether it's a natural disaster. The reality is that because we have the least amount of savings, the least amount of stability, we usually suffer the most in those. And this is no different. And so when we talk about moving forward, what we're talking about is creating systems that address the fact that when these systems were created, in their creation, they were created to enforce a racial hierarchy. They were created to enforce a wealth hierarchy, and people of color were always at the bottom of both of those things. They were always not the target of being brought up, but the target of exclusion. And so when we talk about reforming these systems, that's not an easy task. But what we can do in this moment today is understand the history of that, understand that that history doesn't go away just because we are now all in the same shared space, just because the city council is a majority person of color council. That history of the body, that history of what these systems were created to do doesn't go away. But what we can do now is reform those systems. And I've always said that if systemic racism can be as enduring as your parents' generation, your grandparents' generation, and everybody's generation moving forward, then the cures to those can be equally sustaining if we build them into our systems and we create systems to do that. And so I think it's an uphill battle. I'm not going to pretend that reversing decades and decades of racial strife and racial segregation and racial inequity is going to be something that we can do overnight. But I think that we can create policies and create ways in which those policies address this. One of the ways that we talked about was data collection. When we were in the early days of this, we couldn't get any data. We knew it was in our communities, but we couldn't get that data. I knew from on the ground. I have a district. My district is 75% people of color. When you now see that data, you see that we're pretty high there in total results on tests. But they would talk about social distancing. But how do you socially distance in a home that holds too many people in it, frankly, because you can't afford other homes. You can't afford to rent, right? So there's all these different built-in factors that I think people don't take into account. But where we are today as a society, we're in a position where if you name that and you shame that, there's a reality where people say, look, I don't want to be responsible for that. I don't want to be implicit in what this means. And so that creates the power, if you will, or the calculus to move these types of changes through. And so I think we can do it. I think I think when you sit down and you make the case for what this looks like generationally, when you explain that these disparities aren't choices, these disparities are created by systems, people understand that when you put it in the context of our history, because it's very important to do that.
Okay, so Dr. James, here's the thing that I think about, and that is, given what we understand now, and I hear what Councilman Arroyo is saying about going forward, we're looking at a reopening where we already know there's going to be some more infection. We also are looking at rationing of resources. We're probably already in rationing situations that maybe the rest of us don't even know about. And that definitely is impacted by race and racism. Right? Dr. James.
Sure. So I think perhaps you're alluding to the crisis standards of care, perhaps?
Well, I'm just concerned about that. If we're not naming it and yet, what does that look like when we start going to the reopening and also the rationing of care and resources like vaccines or treatments or testing?
Well, I think what we've tried to do in Boston, I mean, I can only speak to what I've seen, and being on the mayor's, COVID task force is identifying where those needs are in terms of testing, increasing by a lot the number of locations where testing is and where it occurs, and making it accessible to people. And also providing people with the other types of resources to protect themselves and things like that they need.
But doesn't that require you understanding that there are some communities harder hit? That's my point.
Oh, absolutely. There's no question about that. And one of the things they have done, actually, that the task force has done, is to go out into those communities and to find out and understand who needs what, and delivering those things to people in multiple languages and making it easy for them so they don't have to come to us, creating webinars and things like that to them. Okay. There's been no shortage, at least on this end, of people donating, masks and sanitizer and gloves and things like that. And even just yesterday, some people were reaching out for some things.
Okay, all right.
I think those things are, pretty accessible. And I can't say that some people are not missing it, for certain. I'm sure of that as well. But we are trying to cover all the ground.
And Sean, that's my question to you. If you are in a, quote, invisible community, as you've stated, where people don't know you are even there, the numbers aren't there, how do you get the resources that can keep you safe? What are your concerns around that? Because we're at the point now where Councilman Arroyo would like to name racism, but it has not been named in this, nor accepted.
Yeah, and I wanted to kind of just for your viewers, kind of like contextualize. We were talking about the 1918 influenza outbreak, and it was during that time that some of the last wars, outright wars between the United States and indigenous peoples were still happening. And it wasn't until 2005 here in the city of Boston when the Indian Imprisonment Act was repealed. So we have a lot of history that we have to be confronted against. But then we are also putting up, hey, there's a government-to-government relationship. There are treaties that are supposed to be the supreme law of the land, and yet we have this labyrinth of federal Indian law that we all have to kind of navigate. And so where that puts us, NACOB, we're going to our grassroots partners and support, like Party for Socialism and Liberation, like the South Bend Technology Center, our Indian Health Service partner, Native American Lifelines in Dorchester. They're doing surveys of our communities. So it's from the bottom up that we're trying to find our solutions.
Okay. Dr. Gamble, you get the last word with just a few seconds left. What is the one thing that we need to take with us out of this conversation about understanding that racism is connected as a public health crisis?
I think it's important to understand that how you define the problem influences how you determine the solution. That if you see it as racism, it's not just naming it, but is also trying to come up with solutions that look at the broader socio-political context in which diseases operate and in which people die and get sick.
And would you say that naming racism does not make you a racist? just to be clear.
It does not make you a racist. It definitely does not. It just basically says that it is a multifaceted problem. That that it's not just in terms of healthcare. It's in terms of educational attainment. It's a problem also of housing. So that we're saying, let's look at this in a broader context.
Thank you so much. I really appreciate all of your insight. That's the end of our broadcast and the end of our show. Thanks to all of our guests. Thank you for joining us. Stay with us right now as we continue our conversation on Facebook and Twitter.